Thank you very much for the introduction. And I'm really pleased and delighted to be here in this and participate in this webinar. I would also like to thank Professor Wainwright and Professor Lerner for inviting me here. So these are my disclosures, and they are indeed relevant in this talk. So we've seen many cool surgeries today, and do you think we should even consider suprachoroidal surgery? Well, I think so. I think there is a room for this surgery. And in this talk, I will try to convince you. So we are all well aware of the problems of the classic suprachoroidal surgeries. It's far from ideal, and we all know that. But suprachoroidal surgery could be an interesting surgical option for some patients with glaucoma. So first, due to the hypotensive potential it has, we are not going to depend on a bleb, and this is hypothetical. There will be a little impact on the conjunctival alterations on the success rate of the surgery. So why suprachoroidal? Well, we have the very high differential pressure between the anterior chamber and the suprachoroidal space and the supraciliary space, around 4 millimeters of mercury at physiological ranges. So this is important. Then, how does the unconventional pathway works? We have three different options. First, the ACUS can use the uveoscleral pathway to the orbital vessels, the uveovortex pathway to the vortex veins, and hypothetically could use this uveolymphatic pathway. The good thing is that if we bypass the ciliary muscle, we can benefit from this pressure gradient, and then the ACUS will be absorbed by the choroidal vessels or by the venous plexus. So is it possible to obtain or produce a controlled access to the suprachoroidal space surgically? Over the years, we have many options. Modified trabeculectomy to increase the access to the suprachoroidal space, so the outflows to the unconventional pathway. This combined trabeculectomy, cyclodialysis, many types of modified deep sclerectomies, and of course, ab-externo shunts like the Gold shunt or the StarFlow, and suprachoroidal mix. So if we think about an ideal suprachoroidal surgery, obviously it has to be predictable in terms of IOP lowering, not induce excessive fibroblastic response, and of course it has to prevent hypotony. So we've learned a lot in the last 20 years. So we know that fibrosis in the suprachoroidal space is different from the subconjunctival fibrosis. We know that when we insert a device in the suprachoroidal or supraciliary space, we may have a foreign body reaction. And we know that there are inflammatory mediators and fibroblasts that have an impact, or they have a role in this wound healing process. We know that. And we know that when used ab-externo, mitomycin C could have some beneficial effect. But it's very clear that when you introduce a device in the suprachoroidal space, some inflammation is going to be produced, and wound healing and scarring. So probably we can work on that ab-externo devices. But if we think about surgery with implants, probably the natural evolution is to try to use suprachoroidal mixed devices. So the problem, as you may know, is that first we have to be familiar with anatomy. We cannot really see what are we doing in the supraciliary and suprachoroidal space when we introduce ab interno a device into that space, which is virtual. So we also have to learn a lot from the CyPass history. So the good thing is that it works, and you see in the bottom right, there's a CyPass implanted in place. So you see how the lake is, the suprachoroidal lake is produced, and it's very clear there is a flow between the anterior chamber and the suprachoroidal and supraciliary space. And also the surgery is quite straightforward. And then we can even introduce viscoelastic as in the bottom left video. in the supraciliary space and suprachoroidal space, and it seems to be quite safe. However, we cannot use it. And the reason is due to the endothelial cell loss after 5 years when compared to phacoemulsification alone. But this is probably related to two things. First, the device position, and also it's very rigid, so it tends to go towards the cornea when implanted. Also, the indication early to mild glaucoma is important. So, because in this case, safety is a must. So, probably we have to evaluate the position on the treatment algorithm. So, this is just to highlight how, when it's not fully inserted and two or more rings are visible, then it's going to be very close to the corneal endothelium, or even touching it. So, it's going to cause problems. That is not a trabecular implant in terms of safety. So I'm just showing you an example. This is patients who were implanted with CyPass. These patients were refractory to medical therapy, and they were considered for conventional glaucoma surgery, trabeculectomy. And results are not so bad. In terms of more than 80% of the patients, trabeculectomy was not needed during the follow-up. So, and these results were confirmed in the longer 2-year follow-up. So it's true that some patients, around 70 to 20%, needed additional glaucoma surgery. But remember that this was moderate to advanced glaucoma patients, and we are saving quite a number of them from a more aggressive surgery. And here I'm showing you a patient from this particular paper. So advanced glaucoma, and the patient after 4 years is doing quite well, with a pressure around 14 to 16. So, but we cannot use CyPass anymore. So is there any other option? Well, we have one option, which is the Mini-Jet. So this is not a rigid implant, so it's soft, and this could make a difference. So in terms of, it's going to adapt to the scleral curvature, and this is important. This is an early inserter, so things have to improve. This is obvious. But this is the technique, which is basically very similar to the CyPass technique. You just have to insert the device through the iris root and bypass the ciliary muscle, and then inject the device into the supraciliary space. And does it work? Well, it works, and this is the paper that has been published this month. And the success rate was very, very high. You will see here. So the IOP decrease was around 40% from baseline, but remember that there was no washout in this particular paper at any time point. So qualified success rate was 76%, and medication-free patients were 55. So obviously this is very early results. We don't really know what's going to happen with a longer follow-up. But in terms of adverse events, it's very safe. So the safety profile is very similar to the CyPass. And obviously we hope that the endothelial cell impact will be less. And this is the reason why. So on the bottom you can see the CyPass is rigid, it's very straight, and it tends to go towards the cornea, as you can see here when it sits. However, with the Mini-Jet, you see that it adapts to the scleral curvature, and then it tends to move away from the cornea. And this may make a difference in terms of cornea safety. So to end my presentation, I just like to give you some messages. So I think mixed surgery, suprachoroidal mixed surgery, is an interesting option. So I think it's worth to explore. We don't really know if the Mini-Jet will answer the question or other technique or other device, but I think it's worth to explore. It has potential for the treatment of more advanced cases when you compare it to trabecular devices or trabecular surgery. And there are new materials coming and new designs, so hopefully they will also be good and better than the ones we're using now. We have to refine the surgical procedures. We have to be very careful during the surgery. This is probably a surgery for glaucoma specialists. And the key problem is that we really have to learn how to deal with this scarring. And this is, at the moment, is very difficult. Remember that the decrease of the IOP is going to be limited by the scarring and encapsulation of the device. Thank you for your attention.